Thanks very much, Sarah, for the invite, and thanks to the organizers. I am going to talk about somatic symptom disorders, but this is going to be just the first part of the presentation. The second part of the presentation is going to be more, I should warn you, more dry neuroscience. Okay, so this warning is for a reason. How many of us deal with somatic symptom disorders? How many of us are psychotherapists? Okay, and how many of us are in religious studies or Islamic studies? Okay, that's very good. So what I'm going to ask you to do is please bring to your mind your patient with somatic symptom disorder, or your line of therapy, or your knowledge from religious studies to what I'm going to talk about. If you just keep that fresh on your mind, you'll be able to bridge a lot of what I'm going to talk about with your work and your discipline of knowledge. I should just warn you, a question I get often after this very same presentation is, what does that have to do with somatic symptom disorder? So if you keep your patient with you, you will see the relevance. I'll start by, so I come to you from British Columbia. That's the land of the Coast Salish people. And in addition to the land acknowledgement, I just would like to say that on the 21st of August of this year, the government of British Columbia announced that the First Nations population of that province lost 6 full years of the life expectancy over a period of 5 years. So within the last 5 years, they lost 6 years of their life expectancy. I think in a conference in Islamic medicine, Islamic psychology, it's really important that we acknowledge that, and with our values and adl and supporting the other, it's at least important to acknowledge that and do what we can to support the First Nations population of this land. And still with the land acknowledgement, I just wanted to share with you something else. I ran a service for somatic symptom disorders and functional neurological disorders for 5 years. And within these 5 years, we received referrals for First Nations patients that accounted to 2% of the total number of patients in a province that has at least 6% of its population of First Nations origin. So again, let's keep that in mind. And if we want to pride ourselves for having an equitable health system here, we need to remember that equality in healthcare isn't just about equality of availability of services. I have no disclosures other than saying many of you would know that somatic symptom disorder and related conditions are divided into 3 categories: somatization, functional disorders or functional neurological disorder, and illness and anxiety disorder. My main work is with functional neurological disorder, and you will see that kind of more present as I speak and as I go through the slides. Okay, I want to go over the objectives. Now, okay, many of us work with population with functional neurological disorder. What's in common between patients with functional neurological disorder and somatic symptom disorder and illness and anxiety? Like when someone used the word somatic symptoms or somatization, what comes to your mind? And anxiety. And what else? Being body focused. And what else? Trauma. Anything else? Depression. Anything else? Yeah, physical symptoms without physical explanation. Yeah? And through history, I'm going to say the history of medicine is the history of somatic symptoms. Humans recognized symptoms and symptoms that lead to loss of function before they could understand the human body, and long before that. So in reality, the history of medicine is the history of symptoms that were not explicable physically. But as healing traditions and medicine progressed, we understood more and more of the structural causes of these physical symptoms. And we developed rules that link structural changes in the body with physical symptoms. Okay? But yet, there remained many symptoms recognized over centuries that were not explicable structurally. So what did medicine do? It attempted to understand more of the structure to explain the symptoms, or it attempted to apply the rules that were developing to the symptoms. Or if medicine or the healing traditions couldn't do either of those, dismissed the symptoms as invalid. Okay? And this is really the story of somatic symptoms and the experience associated with that. So the earliest history I could find of documented somatic symptoms is from the Kahun papyrus to your left. This is, if somebody is from Egypt, this was found in Fayoum. It's a papyrus from 4,000 years ago. It was found in around 1886, around the time that neurology became a discipline of science. This papyrus talks about a range of vague symptoms that cannot be explained with our understanding of the human body. And these symptoms were happening in women, and hence the name Kahun Gynecological Papyrus. This is how they were named after they were found. Kahun Gynecological Papyrus, acknowledging or claiming that this is a condition of women and exclusive to women. Fast forward 1,500 years, and you would see the papyrus to your right, less than 1,500, I would say about 1,000 years. This is called Eber's papyrus, and it continued to have the same description of group of symptoms that cannot be explained that are happening in women. Now, fast forward. So let's fast forward a few hundred years, and who's there? Hippocrates. And Hippocrates was the one who really established this claim of these symptoms being a condition of women, and he coined the term hysteria for uterus, arguing that it must be that the origin of these symptoms is the uterus. Okay, so basically, over a period of more than 2,000 years, there was a belief that there is a group of physical symptoms happening exclusively in women that cannot be explained by any available explanation. So it must be because of an abnormality in the uterus. Now, the assumptions were that the uterus is roving or retroverted or antiverted, or it's a uterus full of eggs, or unfertilized eggs, or fertilized eggs. And so lots of thinking about what could be explaining these symptoms all focused towards the uterus. And this explanation stayed with us for a good part of 2,000 years. You can see in the bottom of this slide the methods that were used to treat many of these symptoms, starting from very early methods, including actually insemination, because of the argument that some of these symptoms are related to unfertilized ova in the uterus. And going all the way to devices from the 18th century, where the aim was to correct the position of the uterus that is causing these symptoms. Okay. Okay. So the explanation stayed with us until the latter part of the 19th century. Who's familiar with this painting? Okay. This is the birth certificate of neurology. This is one of the very first classes of neurology. Neurology became a discipline of science in the late 19th century, around 1860, 1870. And right in the center of this picture is Charcot, the teacher. And around him is all the who of who in the world of neurology. So the man with the apron sitting in the front is Tourette, if you're familiar with him, of Tourette syndrome. The man who is standing, holding the patient is Babinski, physicians among us would know Babinski sign. And the young man in the back is actually Charcot the son. That's the man by the window who described neuropathy. But the most famous people in this picture are actually the patient, whose name is Marie Blanche Whitman. She's known in history of medicine books to be referred to as, does anybody know? Okay, it's a derogatory description, Queen of Hysterics. So this is the reference that was given to someone with this condition that Charcot himself described as a neurological condition for which the tools of the time were not up to date to explain it. Okay, I mentioned that this is, or I claim that this is the birth certificate of neurology. So again, the history of neurology is the history of these conditions. Okay. Now, other important things in this picture is the painting within the painting. The painting within the painting actually denotes someone possibly with a kind of somatic seizure, a functional seizure. Okay, and there is something else in the picture. I distorted this picture. Can anybody tell how did I distort it? This is not the original painting. Huh? There is a shadow. Whose shadow is it? Someone familiar. So did you say Joe Biden? Freud, absolutely. That's young Freud. And Freud has actually left Charcot's class the year before this painting. So Freud was a student of Charcot who left to study with another psychiatrist, Breuer. And as you can see, Charcot is addressing the condition of patients with symptoms that cannot be explained, claiming that these are neurological symptoms for which the tools of the time are not up to date to explain them. Freud leaves this class and works with Breuer to coin the term conversion disorder, denoting that this is a condition where emotional impulses are converted into physical symptoms. And for 100 years thereafter, these have been the two explanations we're working with. An explanation based on attempting to develop neurology, to understand what is happening there, an explanation based on the idea that there is a conversion from emotional states to physical symptoms. Any questions or comments? Okay, wish me luck. Boom. Look at that. So I say these two trends stayed with us for 100 years. The DSM-1 came out, this is the classification of mental disorders, that came out in 1952, and it was almost entirely based on the thinking of Freud. The DSM-2 came out in 1968, and it expanded a bit on the thinking of Freud of this being a conversion condition to propose that there are somatic symptoms that are unexplained by mere conversion, and in any case, produce to us almost 3 states that fall under the umbrella of somatic symptoms and related conditions. Those are what we call now somatic disorder or somatization. This is a condition that presents with symptoms Number 2 is functional neurological disorder or conversion. This is a condition that presents with functional problem, like loss of movements, for example. And a third condition, illness and anxiety disorder, or what used to be called hypochondriasis. This is oriented towards a diagnosis. So that would be the patient who comes to see you worried that they may have cancer, they may have a stroke. And since then, we've had these 3 classifications under the umbrella of somatic symptoms and related conditions. Wish me luck again. Okay. Now, how can we explain these conditions? Like, really, if you look through the history of scientific understanding, so we want to forget about hysteria. If we look at the history of scientific understanding of these conditions, there are really 4 and only 4 explanations that capture for us what is happening there. The first set of explanations is argue that these are symptoms of activation of dissociated material. So basically, bodily expression of dissociation. Some of us here, we're talking about trauma related to these conditions, and this is indeed emphasized by this explanation. This is the model of, for those of us who are working in neurology, this is the model of the famous neurologist Pierre Genet, who actually introduced the term of dissociation to denote that state in which a human being fails to integrate sensory signals into the meaningful interpretation that most other humans reach. Okay? The second set of explanation is symptoms are hardwired response. So that is basically within our neurons, there is hardwiring that when we feel anxious, the neurons fire and they create these somatic symptoms. And this is the panic without panic model, as they like to call it, which is actually the basis of almost all the cognitive therapies we apply for these conditions. Okay. The third explanation is the more Freudian explanation, the explanation of conversion that that I mentioned a few minutes ago. And the fourth is arguing that this is a learned behavior. So this is the explanation, if you like, that created more confusion, bringing these symptoms together with states like malingering and factitious disorder, where the argument, I mean, we'll talk about malingering and factitious disorder in a few minutes, where the argument is a learned behavior happened in association with certain situations, and that results in the development of these somatic symptoms. If you look at these explanations, though, they are all convincing. And actually, for those of us who practice in this area, would know that this is what we're using to understand these symptoms and to treat them. But if you look at the explanations, post these explanations, there is what? There is paucity of biology. Like, really, you cannot take these explanations further biologically to understand what's happening. I don't know if you're getting this. The point I'm trying to make here is, if we're trying to look at these conditions as medical conditions within the human body, then give me the biology. Give me the biology beyond that. And really, this is where it stops. There is a wall there between these explanations and the biological understanding of the human body as we are at it in the late 20th century, early 21st century. Any questions or comments? Okay. Okay. So, well, these 4 explanations dominated and continue to dominate. The early iterations of the DSM stayed with us since 1952. The Freudian and the neurological conceptualizations stayed with us for 100 years until maybe early 2010s, when a new diagnostic system was introduced, looking at these conditions through a completely different lens. And that completely different lens is actually, if you focus with me, you will see how it bridges with what Dr. Rothman was talking about earlier today. Okay, now 2010, what happened before 2010 that kind of could create paradigm shift? It happened before. I mean, there are kind of lots of disciplines of science emerged in the latter 20th century and early 21st century, and lots of discoveries. We are able to image the brain. fMRIs came about in 1992, and cognitive neuroscience became a field of study. And cognitive neuroscience, if you ask me, I would say it's the offspring of functional imaging, of fMRIs and related technologies. So really, 1990s began to look more into the biology of neurology of cognition, for lack of better expressions. And here, cognitive neuroscience developed, okay? Cognitive psychology has been with us for a long time. Neuroscience has been with us for a long time, but cognitive neuroscience in its current format is really 1990s onwards discipline. And that is what moved our understanding of these conditions from where they have been for a century to where they are now. So looking at these conditions, and I'll talk about where we are now in just 1 minute, you could look at 4,000 years since the papyrus I showed earlier to Charcot, then Charcot to about 2010, and 2010 to now. What happened in 2010 and onwards? These new classifications came about and described to us these conditions as the following. Kind of read, I mean, this is criteria from the DSM. Kind of, just read them, and kind of for those of us who work with somatic patients and patients with functional neurological disorder, look at those. I mean, do they ring true for what you see? Do they kind of look like the ones that will help you, the criteria that will help you diagnose these conditions? Yes or no? Yeah. Any objection to that? Come on. I'm not that boring. Interact with me. They're very vague and subjective. Okay, you are very good guys, because this is a trick slide. I usually show it and people would say, yes. And I would say, except for that it's wrong, because this is how it is. I mean, the slide before this, okay, without the crosses, without the scratches, these are the old criteria. So in 2013, the criteria changed where we no longer are required to diagnose these conditions in association with emotional distress or psychological factors. And this is very important, okay? In fact, the name of these conditions changed too, from what used to be called psychogenic conditions to functional and related, okay? There is something important to notice there. And I don't know how to interpret. You can interpret it in whatever way you like. I mean, here, the 21st century terminology is moving away the word psychogenic, and Islamic psychology is bringing it in. So think about that and think what you would make out of it. Is it a good thing? Is it not a good thing? It's your assessment. Okay, I have my opinion and I can share it later. But we moved away the term psychogenic. These conditions no longer require emotional distress or psychological factors to be diagnosed. And that opened the door wide to so many presentations that physicians among us would know. If you are a cardiologist, you'll be seeing a lot of functional cardiac symptoms in people without an anxiety or such. Like people say post-surgical sinus rhythm palpitations, for example. If you are a gastroenterologist, you have a whole list of these conditions in people who may not be suffering from psychological factors. If you are a rheumatologist, even a lot of people with hypermobility disorders, etc., if you are a neurologist, there is a whole list of conditions. There is almost a functional counterpart or a somatic counterpart to every neurological condition known. Okay, so the thinking is different now. We're no longer talking about emotional distress causing these symptoms. We're talking about emotional distress being important, but these symptoms are related to something else. And that something else is for us to explore together in the next 35 minutes. Okay, any questions or comments? Okay, so I'll run through the clinical slides. And if anybody wants to talk about the condition clinically afterwards, we can. But the fun part is the latter part. Okay, so the kind of comparison between prior and current diagnostic criteria. These are now up until 2013, we would diagnose these conditions based on exclusion. Nowadays, there are some positive symptoms, like any branch in medicine. These conditions are diagnosed on basis of the presence of individual symptoms. And I'm talking specifically, by the way, about the second of the three conditions, that is functional neurological disorder. Again, no need to worry about the details, but I will just show you some examples so that you know what it is. So this is, for example, a patient with functional movement disorder. This is a patient who would have been diagnosed with a psychogenic condition and would have been investigated with so many EEGs and CT scans and MRIs before the diagnosis is made. Now the diagnosis is made on basis of observing certain symptoms and signs, like kind of her knees approximating each other, the asynchronous movements between upper and lower part of the body, the type of tremors you're seeing in front of you. So just all what it needs is a clinician to assess, recognize these symptoms, and the diagnosis is made. The same here for another patient with a wider based gait, almost knee buckling, etc. These are, again, the symptoms we rely on. Here is a patient who will continue with us into the second part of the presentation. Kumari is a patient with, I mean, this is not the real story, of course, is a patient with functional seizures, i.e. somatic seizures, psychogenic seizures, all what we've been talking about. She's diagnosed, obviously she underwent investigations, but now she can be diagnosed with these conditions because of certain features, like say different limbs in her body being in a tonic phase than others being in a clonic phase, side to side movements, ictal crying. There are specific symptoms that she's presenting with that lead us to believe firmly that this seizure is more of a somatic or psychogenic or functional seizure. Now, Kumari is a woman who immigrated here from India. She is of the Dalit caste. She actually witnessed some notorious trauma earlier in life. For those of us who know, the Dalit caste are persecuted in India and they are the lowest of all castes. She saw family members being burnt in front of her. She was diagnosed with epilepsy in childhood, and this diagnosis is correct. And she received treatment for epilepsy. Epilepsy became complicated with functional seizures or somatic seizures that continued with her to this day. She moved to Canada about 10 years ago. She was investigated thoroughly. She's living in really kind of a lot of adversities that we were talking about early with social isolation, non-integration, etc. Her seizures escalated, and all what we are seeing is mostly of the somatic or functional seizures. We'll keep that history in mind as we move forward and try to understand what happened to our patient here. Okay, so I will just skip this. As they like to say, the elephant in the room with these conditions is malingering. Like the question of, are these symptoms real or not? And really, I want to just say that the possibility of malingering within healthcare settings is very, very low. I mean, contrary to what a lot of people believe. A lot of people believe that there is a process of seeking gain by sick role, but in reality, when malingering is assessed formally, it turns out to be a very rare occurrence in healthcare, especially as you go up the ladder, like if you're in a tertiary service or if you're in a secondary service. So I just bring this slide here just to emphasize that malingering is not really a consideration. And I like very much this statement by John Stone, who's I could say one of the founding fathers of today's model of understanding functional symptoms, where he says, proving feigning is difficult enough. Proving the absence of feigning is arguably impossible. Okay, so let's try to understand then what is happening with our patient Kumari, and I'm gonna just skip through those just because of the time. This is not me. So we're going now to think about these conditions and the title, the brain as part of the body. And this is where we can hopefully make a connection between what I'm going to talk about and what Dr. Rothman talked about this morning. So we talked about this patient, we talked about her history, and if I ask you to try and conceptualize her history, what would come to your mind? Can we have a bit of a discussion here? Yeah, what will come to your mind? I mean, you're trying to conceptualize what's happening to her as a therapist or as a doctor, or to start a treatment plan. What would come to your mind? Please go ahead. Trauma, isolation, domestic violence, trauma, isolation, PTSD. Okay, absolutely, and these are all correct. So we are trying to develop what kind of formulation. We're talking about her domestic violence. We're talking about social factors. We're talking about psychological factors, PTSD. We're talking. No one mentioned that she has epilepsy. Yeah, we're talking about biological factors. So we're coming up with what? With biopsychosocial formulation, as any good practitioner will do. Now, one thing, and really, if this is the one thing you will remember from the discussion today, that would be very good. One thing about biopsychosocial formulation that we, especially in psychiatry, tend to forget is that biopsychosocial formulations capture distal causation of disease or of a condition. Distal meaning remote, meaning in the language of medicine, factors that are more relevant for prevention than for treatment. If you want generations of people in the future who don't have functional seizures in the context of epilepsy, let's focus on biopsychosocial model. And I'm not saying that it is not helping in active treatment. It is, but we don't want to overrate the biopsychosocial conceptualization that take us mostly to remote distal causations of the condition. Now, when I say this, a lot of the time there's controversy in the discussion, and this is understandable. But really, if we want to think about what's happening now to Kumari, who immigrated to Canada, who is experiencing these symptoms, what we need to do is bring these four conceptualizations that I presented earlier, and let's see where biology will take us from there. So we can understand what's happening to her now, and we can try to treat what's happening now. So, okay. So let's think kind of simple biology. This is a sensory motor unit. Sensory motor unit is the basic unit of life. Okay, so for a human or a complex biological system, we have five types of sensory receptors. They receive the stimuli in which they specialize. If they receive these stimuli, they fire. They fire. Okay, can you hear me? Okay, they fire action potentials. They fire action potentials, and the action potentials go up the ladder towards the brain. The brain interprets the signal, and the biological system or the human respond to it by one of two things, really: a movement or a gland secreting something. Okay. Any objection to that? Any objection to this being the basic unit of life? Okay. So receptor, interpreter, effector. Receptor, interpreter, effector. And this is how we live. Okay? This is like we have it in the form of cells and receptors. A bacteria or an archaea will have a similar structure, but much smaller. Any problem with that? Okay, sometimes they don't have processors, they have reflexes. So we can argue that the processor is within the synapse. But thank you for sharing that, because, I mean, this is, again, another trick slide. I usually present it, people say yes, I say except for that it's wrong. Okay, so this is wrong, and let's find together why it is wrong. Okay, so onto the fun parts. Okay, if they work. Okay, so now if we think about Kumari using the sensory motor unit, which is actually structurally not wrong. I mean, this is how our bodily structures are made: sensation, a processor of a kind, and response. If we think about her, and we look at what the evidence is telling us about her symptoms, be that the functional seizure you saw, or the somatic symptoms that we see in many patients. Think about these patients and think about the lines of inquiry into what precedes their symptoms. And what precedes their symptoms would be called early warning signs. Is that right? Would be called early warning signs. Now, the new model tried to look at these early warning signs in a different way. The new model of functional and somatic symptoms tell us that these so-called early warning signs are sensory signals that don't usher the occurrence of the somatic symptoms or the seizure. They happen, and the somatic symptoms or the seizures are actually intended to resolve them. So the patient would actually be suffering from intense symptoms, mostly one of two things: autonomic overarousal, like adrenaline symptoms, or depersonalization, derealization. Those will happen, and the seizure or the somatic state will kick in, and these symptoms will resolve. Okay, so the symptoms actually have adaptive function. Again, is what we see as symptoms is something that have adaptive function against the symptoms. Okay, let's try to understand that more. Okay, so who knows the monkey business illusion? Okay, well, anybody who knows it, please don't spoil. Okay. Okay, that's enough. So what is the point in that? Like, what's the illusion here? Okay, that's one way of looking at it. But can you just tell us first what happened? What happened? Like, what did people miss? Did anybody not see the gorilla? Okay. Did anybody see anything else? Excellent. So actually the original illusion was, as you said, was just the gorilla. And about 50% of the people won't see it. But the illusion became very widely known. So they had to do something else. Did you notice that the curtain was changed? Okay. So how many of us didn't notice that the curtain was changed? Okay. So a good 50%. I expect in a couple of years they will update it with another change. But really what happened here is you called it selective attention, and that's one way of looking at it. But for our purpose here, there is another explanation of what happened here, which is the process of sensory sampling that is very relevant to these conditions we are talking about. And who's familiar with sensory sampling? Okay. How many cells do you have? How many cells does a human have? Okay, 40 trillion. Okay. Okay. How many synapses does each cell have? On average? 2, 3, 20,000. Okay. What are these synapses studied with? They are studied with receptors. And what do the receptors do? They take the initial receptors obviously take the sensory stimuli, and the subsequent receptors propagate them forward. Okay. Now, how much does every receptor consume in energy or require an energy to fire? About 2 picojoule. I asked GBT before the lecture today. Can you calculate for me if with these numbers, how much energy does a human have to process the sensory stimuli around them? And it's simply to boil 6 liters of water every 0.002 milliseconds. You can't afford that. You'll go into entropy if you do that. We have to sample sensations. We have to select sensations to sample. And that is sampling that happens for reasons to do with the perceiver, that's me, and for reasons to do with the stimulus, okay? Like that's notwithstanding the accurate point you raised about selective attention too. But the point I'm trying to make here is let's keep the idea of sensory sampling in our minds as an inevitable process in processing of sensory stimuli. We sample a very narrow segment of sensory stimulation around us with focus on prevention of sensory dispersion, okay? Sensory dispersion is very energy consuming, and we cannot afford to do it. So in this slide, as a human, say, because of my experience growing up in a warm place in this world or whatever, I am sampling temperature sensory stimuli here around the level of 10 to the power of 2. 10 to the power of 2 is just an abstract number, just to reflect my own experience and what I'm sampling. If all of a sudden I find myself in Ontario where the temperature is -10 or whatever, what would this count as? This shock of new sensation. This is what would be called sensory surprise. And sensory surprise is a stimulus that fall outside the range of sensory receptors range that the organism is familiar with. Apply this to me coming to Ontario this morning, apply it to a newborn, just being born and facing the sensory stimuli around them. Apply it to a patient with somatic symptoms, who, like our Kumari, or with functional seizures, who all of a sudden sense these abnormal movements in her body as a child. All of these examples denote what is now called sensory surprise, a shock of a sensation outside the range of sensory sampling that a human or a biological system would be dealing with, okay? Now, when this happens, what do you think is going to take place afterwards? think about Kumari, think about me arriving to Ontario to the cold weather, think about a newborn just being born and sensing the world around them and shocked by a sensory surprise. What are they meant to do? Now we know that a biological system is designed, we can use the word design, to narrow their sensory sampling to avoid sensory dispersion. Sensory dispersion isn't in keeping with how a biological system would work. What would the human or the organism do in this situation? Okay, they have, like, really to continue feeling that, they have to widen their sensory sampling, but this is not compatible with biology. So the solution is now they can narrow their sensory sampling where it is and continue, or they can narrow it around the new stimulus. And the new stimulus is more important because it's threatening. So what's going to happen is this. The organism will begin to sample around where the sensory surprise happened. And when that takes place, what is the consequence? There's nothing there anymore. So where they used to feel their normal temperature has gone. They are not processing that sensory range any longer. Okay? Does that make any sense or no? Okay, well, okay, so if it makes sense, this is where they are sampling from now on. What are they doing with the sensory sample? What like, okay, I sampled it. I'm sampling 10 to the power of 4 from now on because I was shocked when I arrived to Ontario. Like, what's gonna happen? What am I sampling it for? Yeah? What am I sampling it? What am I gonna do with it? We were talking earlier about how we sense, we interpret, we respond. And we said, except for that, this is wrong. Okay, let's see what is gonna happen. Okay, so does anybody know the checkers illusion? Okay, look at the white square, the third square in the third row, and look at the dark square, the second and the fifth row. Okay, look at those. Okay, she will move. She moved in front of me before. Come on, move. I beg you. Okay, there's no trick in that. Look when she puts it back, what's going to happen? Okay, so, well, it will go back light again. And why is that happening? Because processing, as it turns out, isn't interpreted. The central processing unit here isn't intended to interpret sensory stimuli. It is intended to do what? It's intended to predict and update predictions. Predict and update predictions. So in reality, there is no meaning to a sensory stimulus. Like a stimulus around you isn't a stimulus with a meaning. A stimulus that you feel is a stimulus that your brain would process to update the predictions that it has already formed on basis of the PTSD, the prior experience of epileptic seizures, the experience of domestic abuse and risk to the body, etc. The brain will form predictive protocols that are simply updated by what we sense as stimulus. And this is what's happening here. And think about it, and you will understand why the brain is predicting dark here and light there, and dark there and light here. So in any case, I think there are lots of slides still to go through. So all what I wanted to say is this is the core of what we see in patients with somatic symptoms. They start sampling in a sampling zone that is distant from where you and I sample sensations, and they They use what they sample, as we all do in sickness and in health. We use sampling predictively using Bayesian, hierarchical Bayesian model. This is just like Bayesian statistics for those of us who are interested in statistics. It's basically about sampling, calculating, and producing new conclusion. Sampling, calculating, and producing new conclusion. And there's lots of fun movies. One point I wanted to say, let's forget all of that. I was going to talk about agency, about the sense of agency and how, yeah, 5 minutes? Okay, so sense of agency. What does sense of agency mean to you? Like when I say agency? Choice, okay, determination. So if I like reach with my hand to get this bottle of water, what am I doing? I am thinking I am thirsty. The water is here, and this calculates the motor sequence, and I reach out with my hand and grab the bottle of water. Any objection to that? Except for it's wrong. Okay, why is that? Why is it wrong? Okay, so this is John Eccles, an Australian neurophysiologist who actually proposed the initial model with which we still believe that we operate. This is not exactly the case. That's in the 1950s. Fast forward 10 years, there's these two German neurophysiologists, Kornhuber and Dika. If you're familiar with them, they discovered the technology has advanced by the 1960s, that they were able to measure low voltage electric potential on the scalp called the readiness potential. It's just like EEG. And Bika, who's in his 90s now, he's Swiss-German, was actually here at the University of Toronto. After they discovered that potential, that electrical potential, he came here, he worked on some ear studies for 2 years, and good for him, he went back to Germany, because when he went back, he was able to discover where this potential is coming from, which is part of the brain, the premotor cortex, that actually calculates among its functions is it calculates and creates these programs that we implement in order to move. So really, if you think about that electric signal and when it happens, likely you would conclude that I would intend to move my hand to grab the bottle of water. This potential will take place, and then my hand will move. Yeah. Now, I intend to move was actually measured about 20 years later for the first time by an American neurophysiologist called Libet, if you're familiar with the Libet experiment. And what Libet found is that the readiness potential happened first, then the sense of agency happened after, then the movement happened. So when me as a human decide to move my hand, oh, hard luck, it's too late. My hand has already started moving. So basically, what Libet did kind of threw a lot of ambiguity around human intention and volition and free will and agency and et cetera, et cetera. And Libet was right. And I know many philosophers object, but what he did was replicated hundreds of times. And technology improved so much. And what he denoted proves itself again and again and again and again. That agency is a sense that happens after an action starts. Apply that to Kumari, and see what comes to your mind. Now, I wanted just to say something about the direction, and I'm really sorry, I really wanted to talk more about that, and you would have seen really lots of fun facts about how the nervous system works in sickness and in health, and how in people with functional neurological disorder and somatic symptom disorder, it works just like you and me, but the outcome is different because of their sensory experience. The one thing I really, really want to talk about is the evolving interoceptive training. Interoceptive training is a fascinating field of neuroscience that is developing now to help patients with functional neurological disorder and somatic symptom disorder. And it's reliant on getting the patients to assess their interoceptive signals. Interoceptive signals meaning signals that are coming from within the body. And what is the target organ for interoceptive processing? What is the target? Does anybody know? Interoceptive, it's really a new field. So does anybody know? It's actually the heart. Yeah. And the argument initially was because the heart is more accessible. But in reality, there is far more to the argument than that. There is far more to the argument why the heart specifically, and not any other organ, is creating the majority of the human's interoceptive milieu. And just to leave it with some clarity, I want to just ask you to imagine something. Inside your body now, you are getting lots of sensory signals, okay? Some from the bowel, some from the bladder, some, okay? Try to capture those. And if you are a neurologist, think about kind of the receptors in the walls of the bladder, the receptors in the pleura around the lungs and so on. And then think about the number of baroreceptors in your vascular tree, your arteries and veins, extensive as it is. Think about the number of baroreceptors and think about these receptors and how they move from sensations, second to second, systole, diastole, systole, diastole. And imagine the amount of interoception that is happening there just around the heart, and compare it with what could potentially be coming from the bladder and bowels. This is a very promising area for, I think, for bridging between knowledge from different disciplines, including what's being proposed in Islamic psychology. I will leave it at that. And I'm sorry again. I really wanted to talk more, but here, you remember I did that at the CPA. My secretary tells me that one day she will hear that security got called to drag me down the podium. So I'll leave it at that, and maybe just, do I have time for questions? Yeah. Okay.
Hello? Excellent. So yes, mashallah, Dr. Gheis is an encyclopedia. And I think also is very effective in helping us understand, how these processes are working in the brain. And I thought it was also kind of a timely or complementary talk to some of what we discussed this morning as well with Dr. Rothman, as it kind of refers to perhaps some of the models or paradigms within Islamic psychology. Maybe building a little bit off of that and coming more specifically to Muslim patients. I was wondering if you could touch a little bit on how things such as religious stress, so examples could be guilt, sin, punishment, etc. How might those impact the presentation of these disorders in Muslim patients, if at all?
So, to the best of my knowledge, the conditions weren't adequately studied phenomenologically in the Muslim world as much currently, using the new model, as much as, say, conditions like OCD have been studied traditionally and how they present phenomenologically in Muslim patients and in the context of religious practice. And I say currently for a reason, that if we go back 30, 40 years, the situation was different. When we were applying the psychogenic model in contemporary practice, the situation was different, because at that time, and actually you might have seen a slide showing the cover of a book titled Textbook of Conceptual Psychiatry, and you and I were talking about that a couple of months ago. That book came out in the 1990s while I was in training. And what they were talking about here is how somatic conditions are destined to disappear from the Western world, because the Western world has become more psychological in its understanding of emotions, and that people are able to describe their emotions as depression or sadness or anxiety, more in psychological language. Whereas parts of the world like the East, they didn't talk specifically about the Muslim world, are likely to continue experiencing these symptoms in their bodies and symbolize them with bodily expressions. Okay, so at that time too, and I admit I was kind of limitations in knowledge can make a big difference. So we did a study on language of emotional expression in the Quran, and obviously a lot of the words of emotional expression in the Quran are bodily. So we were actually kind of wondering if that argument was correct. Now, fast forward 40 years or so, and the situation is completely different. I mean, the somatic symptoms are filling Western hospitals. So for this reason, I really think in current times, there is no phenomenological difference in these conditions until the evidence accumulates between the Muslim world and other things. That's right.
In the allopathic system. So usually if someone has epilepsy, they get prescribed AEDs first. If those don't work, then the ketogenic diet, and then if that doesn't work, then a vagal nerve stimulator. So I'm just curious to know why the vagus nerve is significant. Why is the vagus nerve significant for epilepsy? And did the case Kumari, was there anything resolved in that way? And why is the vagus nerve so important? You hear a lot about it, but when you do research, and I have firsthand experience with it, why don't we focus on the vagus nerve first before the AEDs? Because I think it resolves a lot of other issues too. If you could talk a bit more about it. Thank you.
Functional seizures, which would be treated really differently. But again, like if we think about the traditional management of epilepsy, it starts with anti-epileptic medications, and it will go further many steps before it reaches ketogenic diet or neuromodulation, etc. So if Kumari was being treated for epilepsy, she would be receiving anti-epileptic. I don't think would be her condition would be addressed with any form of neuromodulation. As for if you're asking about neuromodulation for functional seizures, again, it's very experimental. Yeah.
Just to bring it back again, I think to that case study with Kumari, I have a question here through Slido asking, would we say that in her case that the sensory sampling had shifted towards seizures? And does that mean that there's a heightened experience of seizures? I'm wondering if you can kind of bring back that concept to her case.
Sensory sampling has shifted towards the motor activity within seizures. I could say yes. And the sensory sampling too moved towards the two clusters of symptoms that I was showing in the study from 2014. Number one, depersonalization, derealization, and number two, the traditional autonomic overarousal symptoms, i.e. panic symptoms.
i.e. panic symptoms. And obviously, this constitute a sensory surprise in many ways and a threatening sensory surprise. So it's reasonable to assume that this is where her sensory sampling range has shifted.
We have a question here about identifying functional cognitive disorders. I will say that they are kind of categorized within FND and are, somewhat different in that we do have positive signs, but they're harder to kind of elicit on exam to demonstrate to the patient. But maybe Dr. Gheis, if you want to speak a little bit more to SCD.
Thank you. So, as you know, traditionally, functional neurological disorder is a condition of voluntary motor or sensory activity. Now, obviously, with the new model described as we looked at half an hour ago, that opened the door to looking at two other patterns of symptoms. One of them is functional autonomic symptoms, and that's really what colleagues in gastroenterology and cardiology and rheumatology, etc., deal with, and functional cognitive symptoms. Functional cognitive symptoms follow, you could argue, follow the same rules that we were looking at here, but in relation to cognitive performance, where a patient would allocate certain cognitive processing to how they are doing cognitively. Allocate certain cognitive processing to how they are doing cognitively. Attention is a very finite resource. When a patient start to attend, say, to their attention or their memory, using their own attention, there would be very little left to, say, address the external environment. So they may actually present as forgetful, but if that's because of how they are cognitively processing their assumed cognitive challenge. I mean, it's still not formally an entity within the DSM-5 TR, but likely functional cognitive symptoms and functional autonomic symptoms will be very soon, and they will have their diagnostic criteria. And as everybody knows, it will be based on that, based on what we know from motor and sensory symptoms, but just applied to functional cognitive symptoms, as it's a benign condition, but it's very perplexing because obviously it can mask and mislead, etc., in our way of investigating primary cognitive disorders like dementia.
Thank you. And definitely an evolving area with now the biomarkers that we have. But our last question, just in the interest of time, we have someone here who's inquiring about functional symptoms manifesting as a means of protecting individuals from distressing experiences. So, for example, dissociation, and whether cure or what are basically the cure prevention goals and why? Like, how do you kind of approach that clinically?
So, a lot of cognitive strategies, mainstream cognitive strategies, and cognitive processing, not just cognitive therapy, cognitive processing strategies are intended to address that. I think this is also an area where, there is no pharmacotherapies as such indicated for functional symptoms, but this is an area where we can there can be an approach to, say, autonomic over-arousal pharmacologically that will pave the way for management of functional symptoms. Addressing dissociation using interoceptive processing, interoceptive training that I was talking about is a promising area, but is still not there yet. There are like milder forms of dissociation, you could argue, happens within treatment of patients with, say, functional movement disorders, and a lot of physical therapies in these situations would be intended towards managing dissociation by basically maneuvering cognitive functions there. Well, first of all, to thank you, and then really say that within systems neuroscience, systems biology, statistical neuroscience, there is, I think, for what my opinion is worth, is a lot of room to bridge into what Islamic psychology is advising us or informing us with. So, and I hope this will be an opportunity for progress of Islamic psychology and also for informing modern science.
Dr. Gheis, that was an excellent talk, and we hope it's just kind of the beginning to be able to learn more about this important area.